Okay. Again, welcome to the Ozone Train Academy webinar. We do this monthly where we have a guest. This is different than our EBU Mastermind, although Dr. Rubin, I think you might be a participant somewhere along the way with that. You have an EBU, then do your practice in Arizona. But it's different than our EBU Mastermind. This is to bring in other types of topics, even though providers may or may not have ozone or UV to help just keep us all abreast and educated. As Dr. Rubin and I were talking earlier today, you guys are probably aware and seeing the same thing I am in practice and the same thing that Dr. Rubin is, which is that while cancer's been a big problem for decades now, it is still on the rise post-pandemic. And now we even have connections to turbo cancers and so forth. And Along with that, Dr. Rubin also sits on our medical board as one of our experts in terms of oncology. He does a lot of other things too. He's got some longevity patients and athletes and other things as well, but definitely specialty lands in oncology. And I know for a lot of us in the IV space, we attract patients who have had or are currently facing an oncology diagnosis, and we want to help, and we know some things like vitamin C and ozone, maybe mistletoe, some of the things that we can, I always say, dabble in order to help. And maybe even you could consider calling it palliative care for oncology patients. But that is very different than being an oncology specialist. And Dr. Rubin is a naturopathic medical doctor, which gives him, that perspective as well. So he's going to talk on dendritic cells and immune function, immune modulation with those dendritic cells. Some of you might be completely new to this topic. Some of you may know a little bit, and Dr. Rubin has tons of insight, even has some connections and some work outside the country with a lot of testing. I admire Dr. Rubin in part mostly for a couple reasons. One is he's definitely a specialist in this space and spends a lot of time in the research and the proven methods. And number two, I hope you don't mind me saying this, Dr. Rubin, but he's had his own bouts with the
No.
familial things of, the
Oh, in our family, yeah,
we
there's been
all
some things.
have. We all have, right? We've got
Yeah,
family, friends, maybe
yeah,
ourselves who have
yeah.
had to deal with this, and that takes it to a whole new level. So, um, I am very confident you will learn a lot from his presentation. Before I turn it over to you, Dr. Rubin, I just want to remind everybody you're getting our emails, but we have a class coming in this a week from today on Myers cocktail and glutathione. And I want to get into some of the science of that beyond just a banana bag, um, beyond just a you know, hangover IV, how that plays in terms of Krebs cycle and cellular hydration. So I'm really excited about that. I will be in Florida, getting again to a location to be able to give that presentation. But you can register for that on our website, or you've been sent the emails. We also have MSK training coming up in March, neural therapy training coming up in March, and EBU training coming up in March. So, you're good, Dr. Rubin. So, just go to our website, look at events, and look at the calendar. And we also have it on our platform as well. So, um, okay, I think I'm ready to settle down and let you do the talking.
How many people are on?
It says attendees 20 on
Oh,
top of us that are all staff here.
good.
Um,
Hi, everybody.
and Yeah, and they'll keep filing in. We're just 6 minutes in. We are recording this, everybody, so you can take notes. He's going to share again resources and so forth. The slides we don't generally send out, but they are part of the recording. We'll post that as well as send you an email on that, and you can review it. You can share it. That's always a question: is this being recorded? Um, and it might even, I don't know. I wonder if it'll even be relevant to some patient education too.
Oh, so do go.
Do you know how to share your screen, your
Oh, yeah,
slides? Some people use Google Meets a lot more than they use Zoom. I'm a Zoom person, so if you ask me how to share my slides on Google, I would,
like that.
Yeah, looks great.
Is there a way to get rid of us?
I think so. You don't like looking at us?
Well, it just we can't see the whole screen. Okay. Well, hi everybody. I'm Dan Rubin. I'm in Scottsdale, Arizona. I'm a board certified naturopathic oncologist. I actually am. My longevity client or patients that Kim talked about are actually those who have been converted from, people with cancer. So we've been exclusive to oncology practice for, besides dabbling in the realm of HIV for a few years or in the late 90s. For 29 years, it's been oncology and really helped develop what we now call integrative oncology. I'm a board, like I said, board certified naturopathic oncologist. I am the founding president of the Oncology Association of Naturopathic Physicians, which is how I became board certified. We now have, 200 board certified naturopathic oncologists, I think, in North America. Starting Friday, we'll have our 14th conference. I'm no longer part of the board or anything like that, but that's where the specialty comes from. And we have a oncology only practice here. We've got four doctors or five doctors here in Scottsdale. And we have a cancer clinic where my part of the practice is about 80% adults and 20% pediatrics. Uh, so what we're going to talk about today is not relevant to pediatrics only because in order to get this type of treatment, you have to be 18 years old or older. You have to be an adult. And that's just because where this treatment is done, we just don't have a pediatrician. So I have our own clinic. My wife, Dr. Debbie Smolinski, and I founded. It's called Naturopathic Specialists. It's where I'm right now. I practice out of there. We have some other functional stuff that we do outside of practice. But what I'm going to present to you here is I work with a clinic called Immunosine Cancer Center. Immunosine is the technology or utilizes the technology platform called double loaded dendritic cell therapy, which is patented. I'll go through that technology with you. I'm here to show you it. I'm going to give you a financial disclosure. I am a paid consultant to Immunosine. Why? Because I want to help improve the science. I want to, or really not the science is there. I want to help improve the clinical aspects of this, is how it's delivered to patient, who it's relevant for, how people get treated after the initial cycles of this dendritic cell therapy. So after a patient of mine introduced me to this platform almost 2 years ago, I spoke with Matt Halpert, the CEO. We got along. He recognized my long history dating back to the late 1990s when we were making dendritic cell therapies, which are autologous tumor-informed related vaccines for people with cancer. And my penchant for immunotherapy in the world of cancer, and I jumped on board as a consultant, and I play a decent role, and we utilize this for our patients. And I tell you that this is not, oh, everybody should get dendritic cell therapy. It it's not necessarily for everybody. I can tell you that immunosine, when we show you sort of the criteria for who's a candidate, keep in mind this is a global clinic, and around 85% and above of patients that apply for treatment are declined treatment for one reason or another, and mostly it's because Immunosine thinks that this may not be a great treatment for them, which is absolutely and unequivocally unlike any other clinic of its kind abroad outside of the US. That's like a cancer clinic. I've never heard of that before. And that's part of why I wanted to jump on board, was that ethics, because that's very congruent with how we practice. So I really liked it. So I, if you've heard of dendritic cell therapy, great. If you've heard of immunotherapy, great. This is a new type of dendritic cell therapy technology. It's called double loaded. And I'm going to show you what that means. What it really means is we could also call it following normal biology, because we finally found out how the body actually loads dendritic cells. And we didn't know that for the last 30 years, which is why dendritic cell therapy was a relative failure across the board, whether it was an off-the-shelf pharma like well, probably shouldn't say other trade names here, but there was one approved by the FDA for prostate cancer, which just really didn't work well. And then in our previous work, when we were single loading dendritic cells. So This is new, but it's only new to science. It's not new to biology because it is how our bodies work. It just took many years to figure that out. So I'll start. So basically, we have cancer. We're not going to argue about that. And cancer develops from different synergistic mutations, whether it be foods, UV, toxins, trauma, carcinogens, inherency. I mean, you guys are experts on this. You understand this. But our body seeks to eliminate this by utilizing various types of immune cells, whether it be macrophages, T cells, etc. But who's the general? Who guides this? Because it's not just a panoply of things going on. There's an orchestrated maneuver here in the light, and these are the dendritic cells. They are the true generals. What happens, though, is with these dendritic cells, there's usually this communication network becomes broken down. Why? Why do we have this, sort of what we call immunological ignorance? It's because the dendritic cell was somehow unable to gather the required information into itself to then deliver the information to the rest of the foot soldiers, like the natural killer cells or specifically the killer T cells. And we're going to show you a robust amount of data related to this. So let's just kind of set the stage related to this immunological ignorance. Um, it's truly a mistake. So dendritic cells, like I said, they're not new because they've been in our body and it's not a new finding. What's new is how to actually utilize them. These have been around since the 70s. I mean, we've known about them since the 70s. So what they do is they take in cancer information and they process it, and then they deliver it like as a PowerPoint presentation, like I'm delivering information to you right now. They deliver it to other cells that are effector cells that need to know what to do. And so, for instance, how do you deliver information to the tumor cell? Well, you can do it in the form of lysate, you can do it in the form of messenger RNA, and you can certainly do it in the form of peptides because that's how they gather the information themselves. Then what do? There at the bottom of the screen is the dendritic cell, that representation. So there's this hard red line that has been drawn in between the class 1 pathway and the class 2 pathway. And these are the major histocompatibility complex pathways, MHC1 and MHC class 2. And somewhere along the line, somebody said, hey, we need to load tumor information. We need to pack it into these cells in one or the other of these pathways. So either in class 1 or class 2. And what happens when you do that? Well, it doesn't really work because that's not how the dendritic cells do it themselves. So you get this continued immunological ignorance. So then what do? So you could add some stimuli. So maybe BCG, maybe toxin, viral antigens. Maybe we do things that, quote, stimulate the immune system or boost the immune system, and we try and push it along. And you know what? What happens? Well, you get this continued immunological ignorance. So how do you get rid of it? What you do is you take this red line right here on the screen that's, some here for some reason was put there long ago, and you just get rid of it. And you say, we're going to try and double load. And you take information, you take tumor lysate with peptides, and you take tumor DNA, and you pack them, you double load them into class 1 and into class 2 at the same time. Double loading was the term coined by the founders, Dr. Decker and Dr. Helpert. And what happens is you get an entire transcriptome tome change of the dendritic cell. I believe there's an estimation of about 1,100 genes that change when you actually double load. It does not happen when you single load, and it literally becomes like a different cell. You erase this immunological ignorance and you move on. And that's what was discovered. And that is why it's now part of treatment today. There's plenty of peer-reviewed publications, plenty of academic research. So this discovery was made in Dr. Will Decker's lab at Baylor College of Medicine, UT, Texas. That's where that came out of. That's where it generated from. It's all US-based data. Um, So if you take a like, how do you prove it? How do you know that double loading is actually a thing? Well, you have to test to look at output from the dendritic cells. So you take here a controlled dendritic cell, unloaded, just sitting there in a culture dish, and you're going to say like, okay, give it a score. in terms of education, activation, power, memory, migration, whatever it is. At baseline, there's a score of 0. They're not doing anything. There's no information that's been loaded. Then what do you do? Okay, maybe you single load it with mRNA. And you can move the needle, whether it be up or down. Maybe it's a +1, a -1. It's something, right? Because you've introduced something new. Then you say, okay, well, maybe lysate attempts. How does this move the needle? Oh, you got this +2 in terms of immunological migration. You've had some, dips in terms of activation, but it's still something. So then what do? Maybe you take these artificial activators like the BCG that we talked about before, or some other stimulus, and okay, it looks a little bit better. But what happens, and this is data, this is published data, what happens when you take lysate and DNA and you double load, you get something that looks like that. And it's in the world of immunology, and I'm a I'm a in-clinic physician. I'm not a PhD. I'm an ND and a FABNO. But from talking to Dr. Halpert, things that move the needle and that professors or immunologists can build a career upon can move the needle to maybe a +5. And that is, targetable, publishable, fundable. But to see something like these numbers over here in the red, that's life altering for people with cancer. Again, if you look at this clustered heat map, basically it's the same kind of thing. You have genetic signatures represented by these greens and these blacks, matrix looking thing. When you have unloaded dendritic cells, you add mRNA. And again, this is what the signature looks like. It just red lines because they're happy. They've been loaded the way that they should be loaded. So it's not really like a more or less, it's whether or not this is off or on. You can see here, this is the more you load the right way, the more signal. And you're talking about something called an interleukin 12p70 signal, which is an immunological activation signal for a cytotoxic response against tumor cells. It's off or on. It's not more or less. So taking this into account and just looking at the sequence that we need to build, those are cancer cells. Okay, that's the target. Those are in the body. Those are target cells in a tumor in the body. Now, of course, those have antigens. Those are the things that the immune system reacts against. Lots of things have antigens. Just like if somebody takes what we would consider conventional immunotherapy, like a pembrolizumab, for instance, a PD-L1 inhibitor, you're going to be looking at PD-1 or PD-L1 for this class of drugs. Those are either on cancer cells or on tumors or on immune cells, and those are the antigens. So for this model, we're taking true tumor antigens. That's the target. That's the information that you need to feed to the dendritic cells. Again, you have to get info. So to make these types of treatments, you actually have to, and you must, because you cannot without it, you must have tumor information. You need a biopsy specimen. We need about 250 milligrams of tumor, which is roughly the size of like a number 2 pencil eraser. So you need that to be able to get this info. So then what do? You load those antigens into the dendritic cells, and then there's going to be a message that's told to the T cells, the effector cells, those are the foot soldiers, give them a lot of info, and then they start to create this big signal called interferon gamma, which I'm guessing if you're on this call and you're interested in immunotherapy, you understand what that interferon gamma is, a primary killing weapon against cancer. So just a little extract from the data. This is a publication from '06. When you can see here, the more red dots that you see, then the more interferon gamma being generated inside of these dendritic cells. So over here on the left, this is those dendritic cells that are unloaded. They're sort of gearing up because that's what the nature of dendritic cells. You load them with some mRNA, they gear up a little more. You load them with some lysate, they gear up. But when you double load them, what happens? Same thing we saw before with those red lines. That's just what happens. They get all red, they're burning, they're ready to go. So again, I'm just setting the stage. It's the more or less, it's not the more or less, it's the off or on. If we used to be living in this world and the more or less world, like, okay, we're kind of getting a response here. But now that the technology is here, this is the world we get to live on. You're either off or you're on. It's not a thing anymore. So this really for this slide, I'm just going to point you to the middle right here. What's really interesting is when the dendritic cells get information on their own, when they select the info that they're going to take and load into their two classes, class one and class two, they have to be peptide sequences. Yes, the word peptide, okay? Not artificial peptides. These are peptides from the tumor, either from DNA sequences or from tumor lysate. But the idea is that they need to be the exact same sequences. And you can see here, these are the exact same sequences. We're calling these G1 and G2 and M1 and M2. And you can see here dendritic cell signals. The darker the black, the better the signal. When you're unloaded, no signal. Single loaded with just G1 right here, you get a little bit of signal. But if you load G1 and G2, which are identical signals right here, you turn on the dendritic cell. Now, if you double load, but you use different signals, you use a G1 and an M2. So G1 utilizing this peptide sequence and an M2 utilizing this sequence, you don't really turn it on. But then when you double load M1 and M2, you're just proving the point again. And this is published data. This was only about 6 years ago. Okay, so what happens? Why do we care about these types of CD8, CD161 cells? So what you're showing is that you can take a T cell that was maybe just CD8 but wasn't as active as you wanted it to be in terms of tissue homing and turn it on to display cluster designation 161 positivity and turn them into true foot soldiers. These have enhanced homing abilities. What does that mean? Meaning the T cells come out of the periphery and they go into the tumor. You don't necessarily want the T cells in the blood when you have a tumor. You want them in the tumor fighting. So again, they have robust immune and good inflammatory function, meaning inflaming the area, brewing it up, heating up the tumor, getting the tumor cells killed, so to speak. Well, not so to speak, getting the tumor cells killed, actually. So these CD8, CD161 cells are not talked about a lot, but they are your tumor killers. So this is just more data proving the point. So only properly loaded and utilized dendritic cells can generate these. That's what just happens normally, biologically, physiologically in the body. So when we think about spontaneous remissions, maybe a dendritic cell, these stories that you hear, maybe a dendritic cell loaded itself the right way, and the biology that I showed you was followed, and the immune system was unencumbered, and it destroyed the tumor. It's entirely plausible. That's the goal of what we're trying to do. So immunological memory, delaying immune delaying immune exhaustion, cleaning up the margins, targeting seed cells, and fighting relapse. That's why you want these effector and memory cells still there. Delay that immune exhaustion. I mean, if you pound on the immune system, it's going to get exhausted. So there are strategies to help deter that. Cleaning up those margins and those seed cells, those molecular residual disease tests that you look at, the Signatera's, the Guardant Reveals, the OncoDetects out there, when those are positive, but you don't have radiological positivity, but you still see lab data that suggests like, hey, well, you're not 100% free of this cancer. We all know that the immune system is something that you want to target because it goes in there and cleans it up. So that's why having a lasting immunological memory is so important. Okay, so monitoring is then important. Like, how do you even know this is working, right? Well, we'll show you data from the Immunoscene clinic, but let's actually see if we can look at what's happening in the person's body by just doing flow cytometric blood testing. So if you look here, we're looking at this flow diagram, and we're gating for CD3 and CD8, right? CD3, when you have cluster designation 3 on a cell, that means it is a T cell, okay? And CD8 has been called suppressor phenotype in the past, but this is a killer anti-cancer T cell. So this is a CD3, CD8 cell. And what we want is we want everything in here for this in quadrant 2. So you can see before Immunoscene dendritic cell therapy started, the person didn't have these were just not activated T cells. But after just 2 treatments of Immunoscene dendritic cell therapy, you could see that we moved this person to quadrant 2. I mean, it's just right there. You're expressing all markers. Here's another snapshot of this. Now what you're doing is you're looking at CD8 and cells that are loaded with interferon gamma. Remember, the more activated they are in the right way, the more they start to load up this interferon gamma, which is just killing potential. So before treatment started, this person had immunological ignorance. This person was not able to go and attack the cells. And so remember, we wanted in Q2. You see the 0.53, which after only two injections, so this is before the third one, up to 43.3. And you can see the change just in the population of these cells in quadrant two. So these are truly developing the anti-cancer T cells that are going to be specifically going towards the person's tumor. And again, this is not just one person. This is data on patients. And the immunoscene, everybody's treated the same. Everybody gets the same testing. So this is proof. I don't know anywhere else globally that is boasting immunotherapy, especially those that are boasting dendritic cell therapy or some type of immunotherapy, that's actually doing the testing to show. Most are just waiting to see if it works. But this is like, okay, did we actually do it? If not, we've got to do something about it. Again, that's why I'm part of this group. Okay, real-time immune system analysis. This is before treatment started. This is after two, before the third one. And what you're doing for this one, you're actually trying to move them from this quadrant back down, back out of here. You were trying to eliminate these. Why? Because you're looking at T helper cells that are pro-tumor, CD4, CD294. We don't want them. Those are Th2, those are Tregs, they're helper or suppressive. We don't want them. And guess what? Just looking at this diagram, this green triangle right here, you could see, and you can look at the numbers of how they decreased. They started behaving. We took these people, sorry, out of immunosuppressive, more towards immunoeffector. Another diagram right here. This is gated again. So now you're looking at this activation called CD40, CD25, because not all activated T cells are the good cells you want. You can have an activated suppressor cell. And so you want to have an activated effector cell. And what you're looking at here is um, these are gated on CD4, which we saw down here, right? So helper or suppressor, and FOXP3. So they knew that they were CD4 and FOXP3, which are Tregs. So they're looking at Tregs right here, and they're looking to see if they were activated. And you can see how what they did is they took it away from being activated suppressor cells, and these patients became activated effector cells. Just showing you, it's just more data over and over. So there's a sister company relative to Immunoscene. Immunoscene is in Cancun. This is US-based technology, like I said, out of Baylor College of Medicine. There's a company called Diakonos Oncology. You can look it up. There are FDA-approved trials. There are two open FDA clinical trials. One has been completed in glioblastoma, unmethylated. I have some data to show you here. And there's two pending trials, and I believe they fast-tracked phase 2 for the glioblastoma. Pancreatic ductal adenocarcinoma is still open, and there's opening a refractory melanoma trial because we have good data on melanoma. 25 institutions are participating, and I'm telling you, the protocol that was approved for these trials with these, and yes, these are big name institutions who are not going to goof around with goofy technology. That same protocol is utilized right over the border in Cancun. There's no bait and switch. The only thing different would be you can do more. You can do other things. Inside the trial, you can't. You're locked into the trial. Outside the trial, you use the same platform, but many of those patients are seeing people like myself, people like yourselves who are practitioners who are, doing like Kim was saying, intravenous vitamin C or ozone, repurposed medication, supplements, biohacking, whatever the stack may be. And it's really important is when you look at the stack, some of these stacked things aren't going to work as well with immunosine dendritic cell therapy. But guess what sometimes does? There are certain conventional medicines, even low-dose chemotherapies, or if you get these antibody drug conjugates, these work well too. So I'm talking fast and trying to pack as much as I can into this because it's ridiculously exciting stuff because it's how the body works. It's like, I'm a naturopathic physician and I'm a naturopathic oncologist. So this is how I grew up. It's what I tended towards. I did not go to conventional medical school. I went to naturopathic medical school. This is about as naturopathic as you get. You just have to take it out of the body to make it happen. Then you put it back in the body. It's nothing that wasn't in the body before. So think about that. Okay, Immunosine has been a repeat winner of the Breakthrough in Cancer Award. And here's just the NCT designations if you want to take a look. And the refractory melanoma is not included there. So here's glioblastoma clinical trial observation. The takeaway from this slide is that there's you if you're interested or you've dabbled in or actively in immunotherapy, you know there's this phenomenon called pseudoprogression, which means it looks like a tumor is growing back and that they're having progression, but it's pseudo because what happens? You create an immune response in a given space-occupying lesion and you create more cellularity in there, and a war rages. It's going to start looking more active on a PET scan and more dense on an MRI scan because there's more cellularity and there's a lot of biological goo in there, if you will. And so they brighten up. So if you look at patient 006 right here, you look at this lesion, this is pre-op, post-op, and you start following this, and somebody's going, oh, okay, the surgeon, you got to reoperate. This thing is just getting bigger. But if you have patients and you understand the premise and you watch the patient clinically who's not necessarily showing signs of progression, even though every month they're getting these MRIs, you see the adaptation and it eventually goes away at 23 months. Okay, we're talking 23 months for somebody with unmethylated glioblastoma. So just think about that number at face value. 23 months is a big deal. This is a 3 injection autologous dendritic cell immunotherapy is what happened, and this is trial data. Same thing happened here. You can see at 18 months, same thing happened here at 12 months. So, however, if we look at some graphs, okay, here's your historical data, right? Median survival still sticking at 7.7 months. Here's conventional data and then standard of care, utilizing regular standard of care, which I'm not going to go through that right now. There's your median survival. Now, what happens when you give them double-loaded dendritic cells? Well, you're certainly going to change the median survival, okay? And guess what? Not everybody has died. So here's some data here, recreating these curves, okay? What's that data? So let me put one more data point on here. So if you look at this historical control, standard of care only. Now, if you look at the patients who received the double loaded dendritic cells, but whose surgeons panicked or maybe said this didn't know that this was pseudoprogression or wasn't willing to wait, and they reoperated on the patient, these patients died eventually. And now here's the data for people who were not reoperated on, right? So hopefully that makes sense. Going back to those slides, when you're looking at what pseudoprogression, if the surgeon was like, we need to reoperate, and they did inside the trial, this is what happened. If they didn't, this is what happened. It's a big number. This is why the FDA is fast tracking it, is because of that gap right there. And this is published. It's last year. Okay, science and action. So nothing about this basic biological mechanism is dependent on the type of cancer. Ovarian carcinoma, desmoplastic small round cell tumor, I don't know, anaplastic breast cancer, and name it. You have to have a malignancy that has antigens and DNA, and that's all malignancy. So it doesn't matter. Now, Immunosine is not currently utilizing this type of treatment platform for people with hematologic or lymphatic malignancies, just not there yet. But there's plausibility in that. So it doesn't matter. You just need a tumor sample. If you don't have a tumor sample, you can't do the treatment. Okay, over 25 types of cancer. This is a shot from Immunosine. This is just talking about, hey, look, a reprogrammed, rectified, educated, activated immune system is a great thing, but there's still cancer in the body. So can it get rid of all cancer in all people that have been treated? The answer is not necessarily. This is not 100% treatment. So how do you improve this? How do you do this clinically? Well, that's where working with Immunosine alongside of the patient's other doctors or other practitioners is important. Because in some instances, regular checkpoint inhibitors, conventional PD-L1, PD-1 inhibitors, can actually boost the activated immune response and maybe overcome some of the immune exhaustion. Also, Certain low dose metronomic chemotherapies or localized radiation can be beneficial. Sometimes, if you can hit a tumor with a few doses of low dose radiation to expose antigen, expose it, expose outside of the fibrous capsule, show it to the immune system, get the body to see a danger signal and pay attention to it, it goes after it, and you can get a better effector immune response. We work very closely with radiation oncologists out here in Scottsdale. I mean, we have people flying out here to radiation oncologists who understand how this dendritic cell therapy is work and how to deliver radiation so it's not inhibiting the immune system, so it's working with it. So it's really important. Okay. And then certainly there's evidence-based supplements and alternatives can promote a healthier, more robust immune response. Okay, so here's some data out of the clinic. Okay, so what do we got? Here's the different types of cancer. Uh, this is only current through the end of 2025. And so immunosine practically is only around for about 2.5, 3 years seeing patients. So your total N is 116. So again, I'm going to reiterate, this is data that is on the up and up. It's out in the open. There's nothing hidden. You want to know what's going on and what types of patients? Here's the data. I don't know any other clinics of this caliber that's doing this. Again, it's impressive. It's science. And it's also exactly how our physiology works. So a total of 116 patients. Let me move our screen. Oh, sorry. So of the types of patients that have been seen, most of them, like most of us see, are going to be stage 4. Most of them patients with refractory disease. So objective responses are seen in 79% of total, and 79% of total patients are surviving at least 1 year. Here's the thing. These are patients that are at least 6 months post-treatment. That's another thing. If somebody applies to immunosine and they have progressive disease, especially rapidly progressive, this isn't a good candidate for immunosine. There has to be time to get the treatment, to be away from chemotherapy, to get healthier, to revitalize your immune system, and to have this immune therapy work. It doesn't just like go in there and just like blast everything for the most part. There are cases like this where it works very quickly, but that's why patient selection is very critical. And then looking over here, so here's just some more data. So no evidence of disease or survival of 2 years. If patients were eligible, is at 68%. It's phenomenal, hands down data. Okay, let's keep, oops. I don't know. I don't know how to advance my slide anymore. Okay, here's some adverse events. Very little, no grade 4s, very few grade 3s. Fatigue is the big one. Why? Well, it's sometimes tiring to engage an immune response. Some people maybe get tired because they have to go to Cancun, a few times to get this. And I'll explain what the timeline looks like, but very low toxicity. Okay, phenomenal curve right here. This is the overall survival Kaplan-Meier curve. This is historical controls versus immunosine treated patients who were stage 4, were failed conventional therapy. So the blue line is your historical control. If you just look basically at what, 22 months, almost everybody's dead. If you just look at me, let's see, median survival's right about here. I mean, look at the median survival for immunosine. You just look at the curve. If you are selected, and these are uncensored. So immunosine in the early years, as things were getting started, I wasn't part of it at the time, but there wasn't the understanding now of how to select patients. So some people got it and maybe they died within 3 months. So that data is included in here. If this was censored data, this would look even better. But this is uncensored, all in data. And you can just see this Kaplan-Meier curve. That right there should impress you. Okay, how do you work with immunosine? It's not a walk-in clinic like we said. Preferably, immunosine, I'm in Scottsdale. I don't live in Cancun. So when I send a patient, they go, they do what they need to do. I'm obviously in communication as I can with the patient, with the immunosine doctors, but then they come back to me and I'm taking care of them. So I got to know what I'm doing. I don't want to do something, during immunosine because it's basically a 42-day process, and I'll show you the timeline. So working with the patient's doctors, educate. We actually just We were down in Cancun in January, just last month, a couple weeks ago. We took some doctors down there who have been referring, who are interested, to show them the facility, to meet the doctors, because there is a full staff of doctors. There's a hospital that Immunosine utilizes. There's a clinic. We have a full-time medical oncologist, full-time interventional radiologist, full-time internist. I think there's four of them, paramedics, nurses, and then there's the most credentialed hospital in Cancun is Miramed Hospital, which is where the procedures are done. So here's certain, I only have a few more minutes, so, and I do want to give you, I brought two cases of mine. So patients do need to have solid tumors. They have to have a relatively functioning immune system. They have to be able to travel because you got to get to Cancun to do this because you can't do it in the US. It's a 6-week treatment plan, somewhat stable health, and have to have non-infectious status. So there's a small panel of 8 infectious diseases that we look at. And if a patient has those, we cannot let their blood that you would, need for the white blood cells, I can explain that, or you can't allow the tumor into the lab. So these people they have to have a non-infectious status. So in order to, and even talk about this, so you have the tumor, but how do you actually get the dendritic cells to load them into? So getting a tumor biopsy, which most people will go down to Cancun and it's part of the 42 days. And no, they do not need to be in Cancun sequentially for 42 days, but you will get a biopsy. But then you also have to get the cells out of the body. So there's an initial 5 days of immune stimulation, usually using GCSF. And then there's an apheresis procedure. The apheresis is to harvest monocytes out of the blood, which are then taken to the lab, and those are converted into the dendritic cells. The rest of the blood products, the rest of the leukocytes, the white blood cells, I'm sorry, the platelets and the red blood cells and the serum, the plasma, and the proteins are all returned back to the patient during that procedure. It just happens over a couple hours. But you need the raw materials, tumor information, and you need the monocytes. Okay. So these will be, I'm not going to go through these inclusion criteria. It's on the website, and they're going to be, memorialized in this presentation as well. So treatment timeline. So day one, you arrive in Cancun, you get your consultations, your lab preparations, blood work is done, images, and you tend to then get your biopsy because you need to get that tumor sample ASAP. And then you start with the white blood cell mobilization, and then you're gonna somewhere in between day one and day 7, all of this happens. Um, by day 7, this is about what's happening, and by day 14, you get your first injection. So really, some people don't want to stay for the entire 42 days. So they'll stay for the first, say, 8. They get their tumor biopsy, they get their white blood cells mobilized, they get their apheresis procedure, and by day 8, they'll go back home, wherever they live in the world. But they need to be back in Cancun at the clinic day 14. That's when immunotherapy begins. Okay. And these are injected through Dr. Veramontes. He's a board certified interventional radiologist, and they are injected via ultrasound guidance at nearby lymph nodes. So somebody with head and neck cancer is probably going to get supraclavicular. Somebody with abdominal pelvic are going to get inguinal, etc. Okay, then what do you do between day 14 and 28? You can stay in Cancun if you want, or you can go back home. But 14 days later, you got to be back for immunosine dendritic cell therapy number 2, and again on day 42. That's the treatment. All the graphs that I've showed you rely on these 3 sequences of treatment. Here's another this is a hack. This is called Immunosine Preserve. Immunosine Preserve is here in Scottsdale, Arizona. We have a lab not too far from the clinic that I'm sitting in right now. And this is for people who want to preserve their tissue but are not yet candidates or ready for immunosine treatment. For instance, somebody gets diagnosed with um, breast cancer, and let's say it's metastatic, or they're going and getting a tissue sample, a biopsy, and they say, I want to save my tissue. I don't know what the future is going to bring, but I want to preserve my ability to go to immunosine. So I'm going to call Immunosine Preserve. They're going to send me a kit. I get the kit at time of surgery. The surgeon puts 250 milligrams. We send you 6 tubes with RNA later in them, and surgeon puts the tumor samples in the tubes, and this gets sent back to our lab. We process it and we cryopreserve it for a patient who then in the future could go down to immunosine. So why that patient? Well, let's say they go through their cancer treatment, whatever it may be, and now they're free of disease. We can't find it radiologically. They're not symptomatic. So they're clinically, they can't find it on with molecular residual disease testing. And they say, I want to ensure, I want to do everything. This person can now have an immunotherapy or a vaccine made for them because we have the tissue. We didn't have it when the tumor was gone. So they are now candidate for immunosine, most likely. Another scenario, a woman with ovarian carcinoma is diagnosed and requires some neoadjuvant chemotherapy. So goes through, let's say, 3 cycles of chemotherapy and then goes to surgery for debulking, optimal, or with curative intent. It depends. We don't know. We don't know the situation. Let's say it's not curative intent. That's the time to harvest that tumor and send it to the immunosine preserve in Scottsdale, and we can store it. Then the person's going to go through more cycles of chemotherapy. And then what? Is the chemotherapy working? What I'm saying is that if that person wanted to go to immunosine, if that therapy wasn't working, if she was progressing, or there wasn't another opportunity to harvest tissue, that person then would have no opportunity to go to immunosine. You have to have tissue. So start thinking about if this is interesting to you and you're starting to think about patients and things are spinning. Wow, I do have patients that are going to go through surgery. Maybe we should think about getting a preserve kit because this might be our only time to get it. Let's say we have a person with lung cancer who finds out about immunosine at time of recurrence. But this recurrence is, let's say it's in a cervical vertebrae and you can't get tissue from there even though this person wants to go, has low bulk disease as well and is accepted, but they are not operable or not harvestable, they are not candidates. Could they have harvested tissue beforehand if they had, like a partial lobectomy? Yes. That's what immunosine preserve was set up for. Okay, real quick, let's just go through. Well, this is not quick. So this is a person with breast cancer. You can see some of her data right here. HER2 negative. She was truly negative at the time. PR 80%, ER 90%, oncotype 22. This was 7 years ago, right? Because here we are in February of 2026. She had a lumpectomy, surgical stage 1B, all negative nodes. She had a reexcision for DCAS. She came and saw me a couple months after diagnosis. She ended up completing brachytherapy, ended up declining a selective estrogen receptor modifier. And then here's her workup through for the next basic like 3 years, right? She was NED status for all of this. So this is 22. Then I didn't see her for a year. So then she comes and I don't see her for a while, but in January of 2024, she gets diagnosed with widely metastatic osseous disease. She gets a biopsy. Here's some of her statistics. Here's some of her genomics. She gets a PET CT March, so just about 2 years ago. You can see these SUVs right here, just demonstrating for future. And then what we see here, she gets a brain MRI. You can see this large calvarial lesion. She's the one that actually introduced me to immunosine. She wanted to she wanted to go get immunosine treatment, but this, because there were potential changes with the immunotherapy, if there was some pseudo progression, this would have compromised her life. So she needed to get that radiated. And then you can see the cervical spine. You can see some of these, marrow replacements here. And then she eventually commenced tamoxifen. Here's the commenced tamoxifen, and then she had radiation therapy to these 5 areas. 25 days later, she went to immunosine for a tissue harvest, came back to complete radiation therapy. 32 days later, she went back and had her peripheral blood draw. Why this sequence? Because first she needed to get stabilized, so she needed radiation therapy. Then you don't want to radiate all the lesions because you don't want to make them tissue harvestable. So pause in radiation, harvest tissue, go back, complete radiation, then recover from that, get a peripheral blood draw, and then she started dendritic cell therapy. You can see here's just gating of her T cells instead of going through each one of these. I think you can just see here just more robust T cells. You can see here before she even started, and then after only one injection. What did I tell you about quadrant 2? You can see the difference 7.60 doubled. right there. And these are your activation markers on T cells, and this is your interferon gamma. So it's just proving the point. Same thing happened here. This is showing that we're reducing the CD294 Th2 phenotype, taking her from, this is before she had tons of pro-cancer cells, and then it was reduced after just one injection. Same thing here, looking at activated CD161 foot soldiers, CD25, CD161, going from 6 to an 18.4, so you tripled it. Again, now we see her SUVs again. And then this is just some circulating tumor DNA that we were looking at, just basically showing you that as tumor was being destroyed, you can see this increase right here in circulating tumor DNA. It's been a wildly confusing case. These are some other markers. This was an immune response that we did at the clinic. This is just a CD4 ATP release assay. This is pre-treatment. And then just after immunosine dendritic cell therapy 1, it plummeted. Why? You got tissue homing. So the competent cells came out of the blood and into the tissue. And then she started rebuilding her levels, as you can see here. Um, I'm going to skip through these. Now we started to see an increase after treated in some of these bone lesions, right iliac body and the left iliac body. So now we're going, okay, what the heck is going on? Is this pseudoprogression? Is this immune activity? You're looking over a year right here at these SUVs. Now you're looking again. So this is just in August, and you can see we're still having some increase in these SUVs. We don't know what this is. The idea, there's no new lesions. So if I had a little bit more time, I would take you through these cases. I would take you through all of this. The idea is we don't always necessarily know when there's pseudoprogression or not, but I can tell you these lesions are lighting up. She feels good. There's no new lesions. So looks like the T cells are having a hard time they're trying to fight, but there's nothing new. Here's another lady. The long and short of this is taking you through. This is somebody who had in 2011 was original diagnosis and had 4 surgeries. Somebody with breast cancer, 40 treatments of radiation, clear for 12 years. But so just about 3 years ago, she was diagnosed with a new triple negative right breast cancer. Went through conventional therapy. 9 months later, she had pain. She found remaining low nodes. She had 11 positive nodes after conventional therapy. She was started on capecitabine. She stopped because she had palmar-plantar erythrodysesthesia and nausea. She had some deaths in the family here. Then by August of 24, she self-palpated some nodes. My first visit with her was end of July of 2024. So somewhere right in here, I saw her, ran her through a PET scan, and I referred her to get immunosine dendritic cell therapy. Here's her graphs showing you the improvement of these cells, these killer cells going from 11 to 49. And then here's just more data. Here's the similar data. She's in remission. She went into remission quickly. So I'm just showing you that there's data. These data are robust for patients. And I just wanted to say thank you for bearing with me. I know we have some time for questions.
Hey, it went back when you, thank you.
Welcome.
I was stunned. I was trying to process all the big words.
I'm stunned. I was stunned, and that's why I joined. I have a penchant for immunotherapy. I was doing it in the late 90s. So Neil Reardon and I had a clinic called Aiden Cancer Treatment Center back in the day, back in 1999, and we were doing dendritic cells. Nobody knew about double loaded dendritic cells back then. So now, fast forward 25 years later and doing it again, but doing it the biological way. So I love it.
I do too. I, again, respect that perspective for you in oncology. And I think everybody here does. I think a lot of us end up in this space because we gravitate away from the conventional methods, but where can they be useful and where can they be helpful? So we had a few questions come in, and then I have some others that I thought of that might be stupid questions. I don't even know. Um, but the questions that came in also resonate with me. So Regina says, when you say have you seen these questions? When she says, when you say double loaded, do you mean loaded with both mRNA and lysate and peptides?
So what you do is the cells you introduce to the cell culture tumor lysate and DNA, and the cells load. There's a certain patented method to induce that double loading, and that's the patent that came out of Baylor. And here's the interesting part: that those peptide sequences, the G1, G2, M1, M2 that I showed you, those are what the dendritic cells select. They do it themselves. We haven't even dug into the true physiology and the intricacies and the the stunningness of what the dendritic cells do and the intelligence. It's beyond what we even think. They select out those sequences, and if they're not exact, it doesn't work. So the only so anyhow,
Is
yes,
this somewhat accidental? Like, let's see if the dendritic cells will
that was Will
hold
Decker,
this in.
Baylor. That was yeah, that was and Matt Halpert. And I mean, I know Matt Halpert well. We work talk every day. I don't know his mentor, Will Decker, but that's the published articles. They're like, let's see what happens.
Huh, fascinating.
Yeah.
Dr. Scott says, and this was, again, you probably experienced this where a lot of us are somewhat anti-biopsy because of the fear of spreading. So, can you explain a little bit further why that versus using a blood sample with circulating tumor cells?
Yeah, you can't get the samples out of circulating tumor cells, period. The end. You need a biopsy. And if you're in that world where and I'm not getting into that, the theory, I'm not going to talk about it, then the person would not be a candidate for this.
Okay, so they have to go along with it. And it has to be
Yeah,
done
just
there.
don't overestimate the value of circulating tumor cells, and espe I'm going to stop there because this is not my platform, and there's testing, there's some bad stuff on the market, and it's not my platform to talk about it here. So I'm just gonna warn people about circulation. I've been in that world for a couple decades of circulating tumor cells, did some heavy consulting on that platform, and so you got to know what is and what isn't a circulating tumor cell. You can't populate them. You can't. So there's just not enough. You can't extract them from that. You need the true tumor lysate. The
So, does this have relevance for blood cancers?
There is plausible relevancy here, except that we're not using I mean, plausibility for acute leukemias, but we're not doing hematological and lymphatic malignancies at the time.
Okay. Um, Again, this might be a dumb question, but the other thing that I spent so much time hearing post all my oncology training was cancer stem cells, which I believe in many classifications are different than circulating tumor cells. And I'm sure you have some experience with some of those labs that claim to be able to find these stem cells. How does that, is there a relationship between dendritic cells and stem cell, cancer stem cells?
Not something that we can talk about here that's outlined.
Okay.
It's not really it's not like a subject that we would, there's not like a good connection there. I mean,
Okay.
the cancer stem cell should not be, I mean, long and short of it is cancer stem cells not necessarily going to have different sequences. And so, like I showed one slide about cleaning up the margins, cleaning up those stem cells. That's what you want those educated cells out there. I mean, you could literally have an unloaded dendritic cell or a non-educated T cell sitting right next to any cell, whether it's cancer stem cell or not. It might not do anything. I mean, think about melanoma. 2% of your skin is dendritic cells, and yet people get melanomas.
Hmm. Didn't know that. Didn't know 2% was. Along with Regina's next question, and you alluded to it, and this is what you do in your practice. I've been there. How do the rest of us play a role in this? Number one, are we even tapping in for most of our patients to do ozone, vitamin C, et cetera? And number two, um, it sounds like there's a place if we as providers want to send somebody over to Mexico because they're a candidate, because they say yes, because they have the money, whatever, where do we fit in with our whatever you want to call them, ancillary
Yeah. Well,
services
that's
or
what I was talking about with that one slide of like, we want to work with you. And so obviously I can't say, okay, make sure you give them ozone and vitamin C. Like that's not the appropriate way to start working with somebody. But there are platforms and there are doctors who will communicate with the local doctors. You have to be careful and you have to, there are patients whose Dendritic cells perform poorly who have had high dose vitamin C. And when I say high dose, anything above 50 grams. Let's say anything above 35 grams, right? Frequently. And so sometimes we're like, okay, let's, and look, I think I still have one of the world records for introducing high dose vitamin C. We gave 360 grams to somebody in 60 hours back when Reardon and I had a vitamin C clinic. So, and got all our data. We figured out all the kinetic data. Like we gave a lot of vitamin C, and more isn't always better. You have to know how to utilize IV vitamin C. And if you change the physiology too much because you're introducing a sodium bicarbonate, a sodium EDTA, changing the pH, you are going to change migration status, behavior, genomic signature, phenotype of your dendritic cells. So there really is getting to feel this out and how to utilize it. I'm around for this. Janet Mandel is around. There are doctors in this world who are working with immunosine who are starting to understand this. So sometimes not giving something is better than giving something in this. And it
Okay.
and that's if the people that are truly interested in this, those are the people who are like, okay, yeah, let's educate you, let's work with you, let's bring you down to Cancun and show you, talk to the doctors like myself, or like, I mean, I'm not super on the clinical side. I'm more on this side, and I'm doing the immunosine preserve that, and eventually immune testing. I mean, there's a whole world out there of this testing that's right now because the flow cytometer is in Cancun, but we have ideas for looking at how do you preserve somebody's immune function? What if somebody, well, I should probably stop there, but yes, there's other things in this world that immunosine is looking to do because this is true engagement. And when I say true, I mean ethical, actual engagement of the immune response, how it should be, not just giving Coriolis because it has high PSK, Turkey tail, or doing red light therapy because we think it's going to, good for the immune system. There are a lot of times when we don't know what we're doing. I do huge amounts of testing commercially, whether it be through the commercial labs like LabCorp, Quest in my practice, or some of the specialty labs to try and figure out what's going on. Because just because you think you're boosting the immune system doesn't mean that you're not creating those 294 cells.
Mm.
That's needs to be spoken loud and clear. Especially things work great on Instagram, but don't work in real life, right? That's what I talk to my patients about a lot. Like things work, well, works great on Instagram, but so you just, you gotta be careful. You gotta know what you're doing. It's oncology. You gotta know what you're doing. It's why I only do that, but I haven't done anything else for 29 years.
What got you into oncology? Well, I mean, you said back in the 90s you were interested in immunotherapy, but what drove you oncology?
Oh, no, no, immunotherapy in oncology. It was the stuff, uh, because especially back then, and especially we don't know why cells have this change and why they continue to grow. And it encompasses all systems of the body. And it's pretty much the only time that you're trying to use treatments to kill off only little parts of the body and not the other parts. And and look, I'm a philosophy major in college. I was not a scientist. Was not intending to go to med school. And cancer is so wholly philosophy. There's so much philosophy in it.
Mm.
And I think I just fell into it because it was like, wow, this is going to entertain me for a career. And I get to, I mean, honestly, as an existential philosophist, I was trained to create arguments. And so we didn't know much about cancer. We still don't know that much. Now we know how the immune system works, a lot better. I write arguments all day, every day for my patients. We all do. And so family practice didn't hold that. Cardiology is a little more cut and dry. We don't know cancer. So anyhow,
Hmm. Um, you mentioned FDA fast tracking this therapy
for
um,
the glioblastoma trial,
for the
for
glioblastoma
yeah,
trial.
into phase two, they were like, okay, you're doing it. Yeah.
Is that the only one? Is that where this sits in terms of FDA recognition?
So there was three trials. Remember, they're opening refractory melanoma, which may actually be open. I'd have to ask. Pancreatic ductal carcinoma is open, and then glioblastoma. There's other ones in the pipeline, but those are the only two or three that are current. And they have NCT designation, so those are searchable on the NIH database.
This is probably off topic and a little philosophical, but it makes my heart happy to think that the powers that be are at least a little bit interested in something that's working. And I think I'm, yeah, you kind of tug at my heartstrings with that, with this presentation.
Well,
It's um it's really good to hear. Um, okay. I think that we're 6 minutes over. I think that you did a phenomenal job at letting us know that there's hope out there, that there's other options. I think at the end, I think we all have, again, it could be family members, it could be those close to us, it could be ourselves, it could be our patients. What's the process if we want to find out if someone's a candidate for this?
it's incredibly simple. You go to immunoscene.com and you press, boom, apply for treatment. Right there, a button right at the top. Immunoscene.com.
Okay.
Yeah, that's what you do. And then it's
Immuno-CINE.
immuno, CINE, which we should probably put in the show notes. And then they'll probably get an email or a call from Nicole, who's US based, and she starts taking people through the process. Then, look, people have to go through a rigorous medical evaluation before they're accepted. I mean, this is big stuff. This isn't like a walk-in, like, okay, we're just going to go. Like, you have to be evaluated, talk to the CEO. Like, there's processes in place. Probably, I think it's about four doctors have to go through and do the medical eval before and then you're either accepted or denied. Then you're accepted. Then and nobody pays anything for this. These are all free services. You don't pay until you are given a date and then you say, yes, I want to go. And so there's multiple time points that you hit during that time, and that's when you pay. And then it's one cost. There's no hidden cost. You pay once, and that's the thing. It's great for that treatment.
For all three pieces
Yep.
of it.
Yep. And
Um,
everything that comes, all the blood work, all the scans, I mean, it's not just like conventional blood work, tumor harvesting, all of it, all the scan. There's a whole gargantuan workup. Genomics are done. It's all in Mexico. It's all,
okay.
yeah. And all of that's listed
That
on the site. If people are wondering, well, what do I get? It's all listed on the site.
And then if you are a provider recommending them, then Immunosine will help you as the provider know how to support them in between or maybe get their immune system back where it needs to be before they can be accepted.
Um,
Does that kind of
in
come
a,
back to
in a
you?
way, yes, they will. The doctors there do make some recommendations to the patients. And yes, working with the doctor is encouraged. But they don't. There's not like a set protocol, like okay, just take this. But there's more of a let's maybe don't take this because we found that this doesn't, this may hamper the production of the vaccine or something like that. So
Okay. Of course, everybody wants to know the cost. Do you want to disclose it?
yeah, no, it's $120,000. That's the cost. It's all in. Check the website. Most people think that this is it's sticker shock. It's not when you get down to it. You'd be surprised at 85% of people are declined. This is global. People they want to go, but it's not for everybody. So this is expensive. So it's probably a $500,000 treatment in the US, but in Mexico, it's easier to get this stuff done. There's there's other injections that go along with this. The whole protocol is on the website. I wasn't going through the whole protocol. So it's an enormous amount for that amount of money, especially for what you get, especially compared to other clinics, quote, like it in the US that are, you
I
know,
refrain from asking that question. How does it compare to the other dendritic protocols that I'm positive you're aware of and probably have
oh,
used?
it doesn't. They'd be infringing on patent. There's no comparison. You're either double loading or not. It's either off or it's on. Period. Full stop.
By the
And
way, have we found anything? I don't want to say naturally because you've been very clear that this is a natural loading of dendritic cells. But is there anything that has been shown, a supplement, an activity, a stack that like helps dendritic cells turn on?
no, not that I know of. Do you mean turn on, go find tumor and double load themselves?
Yeah. Yeah, almost like you
No,
said in
not really.
spontaneous remission that maybe these dendritic cells figured it out on their own and they did their job.
Oh
Is
yeah,
there
no, no. Well, no, you'd have to study those patients before and after, but they've already spontaneously confessed. So yeah. There
Yeah,
is.
because we think, right, that we're gonna turn on the, what did you call it? The general. We're gonna turn on the general of the immune system with our EBU or our vitamin C or our UBI or whatever. And are we really turning on the general of the immune system?
Most people don't test enough, or they're just doing like mold testing or hormone. You got to
Is
test
there
it.
a test?
No, well, I've created, the sauce that we use here but it's all, yes, I have a compendium of tests that we've used commercially, and then but you have to, it isn't like just go run these tests and you'll have a yes or
Yes
no.
or no? Yeah.
It's a whole clinical acumen and working for almost 30 years on this. And so it isn't like I couldn't give a presentation about it per se. So yes and no, but there isn't a test to test dendritic cells. But I was showing you all those cluster designation. So you were testing T cells or you weren't testing dendritic cells. Dendritic cells just deliver the message. Then the T cells go and do the work.
Got it. My last two-part question though. Um, are you at all, I don't know the answer to this, are you at all open to hosting anyone who does want to come see what your process and what your place looks like? Second part of that is, can we refer patients to you?
To me, like at our clinic or, oh yeah, you can totally refer patients here. That's a giant question. The answer is probably not, because we get asked that all the time. I'm only in clinic, not even 3 full days a week. We have other doctors here. Yes, we have a pretty comprehensive way of referring patients here. We take care of peds. We take care of, we have several doctors here, and we all work as a unit. Um, but somebody that would have to be on a, case by case, because it's
Okay.
hard to,
Yeah,
that's not an
shadowing
easy question
is,
to
yep,
answer.
hosting is a whole ordeal and maybe even proprietary. So I
Yeah.
totally get it.
Yeah.
We'll put that in the show notes, whatever information you give us in terms of referring patients to you as a stateside oncologist and probably even liaison to immunosine if
Yeah.
that makes sense. Um, and I think I don't know. I think you're amazing. I appreciate your time, your expertise. I think the whole group does. We've already had some comments about what a great presentation it was and just
Thank
again
you.
opening up options for us.
Yeah, thank you. All right. See you guys later.
Hey, thank you, Dr. Rubin.
Bye.
Have a good night, all.